Uh, Good afternoon. I have nothing to disclose. So, cholecystectomy is really a bread and butter surgery for acute care surgeons, and outcomes are always going to be of interest to us. We were looking at the time factor in our paper, and our colleagues had studied the time factor previously for early cholecystectomy, less than 72 hours at the time of ED admission, and had found the perhaps expected outcome that early has better outcomes overall. Unfortunately, that's just not reality. Patients don't know that early cholecystectomy is better, and in reality, you're going to see a variety of presentations, and what we wanted to understand was what can we do within that delayed cholecystectomy group, and how can outcomes be examined to perhaps guide us in terms of timing, specifically as to whether we cool them off. We were doing a Sparks database study, so we were able to look at other factors that affected clinical outcomes as a side. So what we did was a retrospective cohort study where we looked at delayed cholecystectomy timing, and we looked at 3 to 4 days, 5 to 6 days, and greater than 7-day groups, and looked at any complication, length of stay, and then the 30-day ED visits, readmission, mortality, and also bile duct injury rates. To answer our secondary objective, we looked at a case control of this Sparks database where the outcomes were examined in turn and looking at risk factors, one of which was delayed cholecystectomy timing. This was an IRB-approved Sparks database study where inclusions included all adults. We excluded anybody under age 18, any of those who were non-operatively managed, those who were in the early cholecystectomy group or who had data issues. And the 3 groups were as previously described, and we matched all groups for patient demographics and comorbidities. Our outcomes that we looked at were, as we discussed before, and so what we saw here to start our analysis was we decided to look at our annual trends, just overall, where were we at with timing and cholecystectomy. And what we saw was that in our sample, it was overwhelmingly popular to do cholecystectomy early, but that's not what this study was about. That we already kind of knew. So we were looking in that group from below. And so we found that overall early was better, but we also found that the philosophy of cooling off the gallbladder when they present at 72 hours or later is actually not popular, at least in New York State. It was much more common just to take them earlier on. We also found that overall people became more aggressive about doing a cholecystectomy early at an increased rate of about 1% per year. When we looked at our groups, of our demographic groups, we found that overall early delayed cholecystectomy was more common in Caucasians, females, those with commercial insurance as opposed to Medicare, Medicaid, and patients in an urban environment. Again, we examined New York, so we looked at the central areas as well as the metro area. Our forest plot here shows our comparisons. So what we do is we looked at our 3 to 4 group and we compared it against the very delayed group, which is greater than 7. On the left side of this image are good outcomes or odd ratios that favor wanting to go 3 to 4 days as opposed to greater than 7. And we see in comparing those patients who are already delayed, those who, at least within that delayed group 1 earlier, fared better in terms of any complication, length of stay, 30-day readmission, 30-day ED visits, and mortality. A similar trend was observed when we compared our 5 to 6-day group to greater than 7. So what this is kind of saying is that gives us pause to consider taking our patient earlier rather than letting them cool off when they present in delayed fashion. And when we compared, finally, the groups within the earlier side of the delayed cholecystectomy group, we found that there was also all these trends with the exception of mortality. When we looked at the bile duct injury rates, overall bile duct injury rates are rare. And so we didn't find enough patients overall to be able to, I think, make a conclusion one way or another. I'll leave it at the fact that there was a trend, and in particular, when we were doing our analysis, we modified our CPT codes at one point to make it more comprehensive, and it actually bolstered our trend. And we think that if we had been able to capture more patients with bile duct injury through the coding issues that we were processing, we think that there might have been something here. So why do people come delayed? Why is it not enough that we just say, we just tell them to come as early as possible? Well, there's cultural reasons. In particular, some cultures don't want to be disruptive to the doctor. They don't want to create an onus or a burden. And they tend to come when it's much later and more advanced. Some patients have fear of the OR. They've never had surgery before. They don't know what it'll be like. Some patients need preoperative workup. We've all been there while waiting MRCPs. And comorbidity management is also a factor. One other factor that we didn't have a great explanation for was the Medicaid, Medicare versus commercial insurance, but we did find that here. Our limitations is, and finally, our limitations of our study is that this was a large statewide database, and like any large statewide database, your data outcomes are only as good as the input going into that database. We also encountered several coding issues. So to capture our patients, we were using CPT and ICD-10 procedural codes. And as we went through the database, it's a comprehensive process, and we found some issues along the way with being able to code, and how can we capture a diagnosis through procedure codes was really the challenge we struggled with. So thank you. I'll take any questions at this time.